So welcome to a short lecture on assessing and treatment planning for your client. So we're going to look at assessing as the key to treatment planning, as how can we plan a treatment if we do not have intention and goal. We're going to cover an approach called SOAP, Subjective, Objective, Assessment and Planning. And this is a really simple and basic but common approach used in many different types of therapies. We're going to talk about posture and how muscle groups working as agonist and antagonistic pairs can have an impact on what we see and how we treat clients. We'll talk about some common posture types that you'll see in practice, and we'll also discuss some common approach or thought patterns as to what might be going on for those postures to at least give you a starting point when you start to look and observe your clients. We're going to look at how you observe that posture, that gait, that walking, and how you then take what you see and turn it into a strategy, a plan to get your client feeling better. And we're also going to talk through a hotspot checklist, which in those early days when you're not as confident with what you see or marrying it to what you hear, you can start and be assured that you will definitely find lots of useful stuff that will help your clients feel better. So the SOAP approach allows a simple approach to note taking, but also a very effective one. The S stands for subjective assessments. This is the facts and the data. This is your screening form. This is what your client tells you, what they write down. It's all of the facts and data according to your client. Next is objective assessments. Objective, what do you see as an outsider looking in? We're talking about visual assessments, postural assessment, how they move, how they walk, what you feel, what you see. So there are objective assessments, which are really important because often what someone feels can be different from what you see. We then talk about assessment, and that's your assessment as the therapist. So after doing the subjective and objective assessments, this is where you think it through and hypothesize as to what you think is going on. Once you have a clear view of what you think is going on, and your client and you have agreed a goal of what you want to achieve, whether that's reducing pain, improving mobility, whatever that goal is, you put the two together to come up with a plan, and that's what the P stands for. This is to cover your short term, so what you will do in that session, your longer term plan in terms of what you want to achieve with your hands-on work, and also the home care, as that's where we're really going to start getting the client better. SOAP. So here we need to become a detective. Especially if you're doing your form online, for example, people are filling in all the questions before they see you. It can be too easy to just check what they've said yes to, what they've said no to, rule out any red flags and move straight into the observational assessment. But then you would be missing out on a really great opportunity for fact finding. So you're going to collect their past medical and injury history, but we're not going to leave it at that. We want to know when it happened. How did it happen? Was there any surgery required? Were there any fractures? How did they heal? Did they heal quickly? Did it take longer than expected? Was there infection? So you're starting to piece up how well this person heals. Maybe also the kind of lifestyle they have. It also gives you a clue as to how someone might behave. Often clients will come to you with pain and they've never had an injury in their life. And actually they might be scared about this injury. It's suddenly stopping them doing things. Or maybe they don't know what happens when you have an injury. They might not understand that they might need to rest or the different phases that they need to go through. So really important we understand not just any serious medical injury, but any injuries they've had in the past. Any fractures, scars, muscle strains, tears, or any repeated injuries. They're the ones people forget to mention, like, oh, I always have a bad back, I don't worry about that. We need to probe. General health at present. So everything looks good on the form. Actually, how's their general health? Have they been suffering colds? Has there been a pattern of illness after illness? Are they showing that actually their immune system's quite low, or maybe they're not in a state of good well-being, for example, which is having a knock-on impact on their tissue health, or potentially on their healing health if they've now injured. Activities of daily life. So often we'll have a box saying occupation, perhaps, on your form. Okay, they could stick anything in that box, but is that really useful to you? You want to understand that. So, okay, they work in banking. What do they do? Do they fly a lot for work? Do they sit at a desk? What kind of desk do they have? Is it a standing desk? Is it a desk that can move up and down? Have they ever had a desktop setup assessment? Things like that. What is it they do? If they're a mum, so their occupation, housewife, mother, maybe they've left it blank. Are they picking up lots of toys all day, carrying children? Maybe it's a job you haven't heard of. Probe, probe, probe. Because yes, injuries can happen in the activity they do once every week, once every fortnight. But perhaps the activity they're doing day in, day out is what's creating a movement or lack of movement in the body that's then putting them at risk when they do a certain hobby. So never underestimate those activities of daily life. Also, they will play a big part in home care, because sometimes making small changes or giving small exercises they can integrate into their activities of daily life will have a far more profound impact than simply giving them an exercise to do 10 times a day or 10 sets twice a day, 3 times a week. Hobbies, right? Hobby to one is almost competition to others. So what do they mean by their hobby? They might play casual tennis once a week, or they might be playing 10 hours a week and competing at a high level. Also, this gives you some insight into their personality. Are they about social interaction, relaxation, or is it competitive? This will help you target not only how that hobby might be impacting them, but also home care again. How are they going to be compliant? What kind of thing are they going to like? Do they want a challenge, or do they want something they can integrate into their life? Then we talk about their current complaint. So they've come to you with, I don't know, hip pain. Okay, that's great. Where do you feel pain? Front of the hip. Lovely. Waste of a question. Where? How often? What kind of pain? Is it there when they wake up? Is it there when they go to bed? Is it constant? What makes it worse? What makes it better? Is it sharp? Is it acute? Is it dull? Is it an ache? Is it just always there? We want to understand, one, the red flags. If it's acute, it's stopping them walking, it might be that you are not the right person to see this if it's an acute injury. But maybe it's been there for weeks, months. There's just oversensitization in that tissue. Or they're doing a repeated activity that's causing this. So we want to ask those questions. When did it start? How did it start? Did it build? Or was it more acute? Did it suddenly happen? Was it very painful and it's improved but not gone away? Or has it been building and building and building? Maybe talk about the discomfort chart. Scale of 1 to 10. Is it stopping them doing things? Start to get a level, some sort of comparison, so that when they come back, you can see, has it improved? Is it the same? What's going on? Really getting your client to zone into their body and explain what's happening. Now, remember time management. You're going to get much better at this, and you can be the detective without spending 20 minutes on your screening form. You will get good at knowing what questions to ask and also what level of detail to ask. So you don't want your clients to feel cheated by not having too much hands-on time, but you do need to do a thorough assessment. And that's where perhaps having an online form saves you time. 1, you'll see red flags before they appear. 2, they're not spending 5 minutes filling the form in, so you have more time to be detective. And 3, You can prepare the types of questions you want to ask, as this will be quite new to you in the early days. So think about creating an online form. There are lots of free applications and software out there. Wufoo, Cognito Forms, and many, many more. But remember, you must comply with GDPR, data privacy, and get their permission. There's a module on this in the business section. Next up is objective. But before we talk about objective assessment, we need to understand a little bit more about posture, about what you're looking at, so that you can interpret what you see into what might be going on. Firstly, let's talk about muscles and how they work together. And I like this little illustration as it's really, really simple. So let's just presume over this little joint, we've just got two muscles, the muscle on the left and the muscle on the right. So when we're neutral, that joint is in neutral, those muscles are the same length, for example. They're at their resting length. Now, I want to move. I want to bend this joint, flex this joint. Well, if both muscles are exerting the same level of force, I wouldn't be able to move. So in order to flex this joint, I need the muscle on the right to shorten. But in order to do that, the muscle on the left must lengthen. So in its most basic form, movement across a joint becomes muscles working in pairs, agonist, antagonist, one group shortening, one group lengthening, one group contracting, the other group relaxing. And this is really important because when we look at joints that are perhaps in their resting state, not in neutral anymore, maybe they're in that flexed position when they're relaxed, we've somehow within the body created an imbalance. A muscle that's locked too short, so stuck in that short, contract, flexed mode, and a muscle that's perhaps also tight because it's being pulled long into that joint. So in order to regain neutrality, so if we look at this picture of flexion, if that has now become your client's neutral, their resting position, we want to lengthen on that right side, so we want to open the inside, but we also need to get that left side to shorten, so we need to strengthen it. So it becomes about this balance of opening up and lengthening and engaging and shortening on the opposite side. Now, what sometimes blows your mind is that generally, and a lot of the time, where they complain of pain is on the long side. Because that muscle's weaker, perhaps. It's certainly longer. It's being pulled long all day long. It's oversensitive. It's feeling pain. Because that short muscle is perhaps overdeveloped. Maybe it's really strong. It's not in pain. It knows what it's doing. It's just doing it too well. So sometimes, both explaining to our clients and you interpreting what to do, we need to work on that short dominant side to open it up, to allow the longer weaker side to offload, to get strong and to start feeling less pain. So we absolutely want to desensitize. We do not ignore where that pain is, desensitize. But in terms of our goal, our intention, our objective is about desensitization, the lengthening, creating space, the opening style work that we want to do with our hands is actually on that short, locked side. So here are some common posture types. First one, really straight, rigid back, no mobility, no movement going on. Often ends up walking in quite a military stiff style, a lot of impact through the joints. We then have a kyphotic lordotic posture where we have too much curve in that thoracic spine and then to compensate too much curve in that lordotic spine. So a really exaggerated S when we look at that person from the side. We'll often see people who just have lordosis, so the thoracic spine looks quite good, moves quite well, head's in a good position, a lot less forward than that kyphotic lordotic position we see before, but a lot of tilt through that pelvis, a lot of lumbar spine shortness and shortness through the front of the hip. The next, where the hip looks pretty good, but we see this arching through the mid-back, the thoracic. We call that a kyphotic posture. Again, we see that head come forward and drop down. And then sometimes, less common, we'll see this curve when we're looking straight on to the spine on someone, and this is called scoliosis. In the first one, we're seeing it in the thoracic area, and in the second, we're seeing it a little lower, entering into the top of the lumbar as well. This can both be congenital and it can also be functional. So someone can develop this, especially females in their teens, young women can develop that scoliosis. But we'll also see a lot of functional scoliosis. For example, someone who does a lot of one-sided activity. Golfers, I see this all the time, where they get a really, really short and dominant right side in the right-handed golfer, and they end up getting a functional scoliosis. Either way, we're not going to fix the congenital scoliosis, but we can absolutely desensitize, soften the tissue, and help increase mobility. With the functional, we can make a world of difference with the right plan and the right home care. So I'm just going to look at lordosis to give you a little bit of an example of more detail as to how the muscles work in pairs. So if we look at that first picture there, a neutral pelvis, we see zoning in, I suppose, on those main muscles supporting that pelvis. We've got the abdominals on front, and we've got the lumbar muscles at the back, QL, erector spinae, those muscles. To the front, we have the hip flexors and quads, and to the back, we have glutes, hamstrings. So if everything's working in balance, as in that very simple joint, everything's at a good resting length and in balance. Sometimes, though, that balance can shift. We get this anterior tilting of the pelvis. So can you see that the front of the pelvis has dropped down and the back of the pelvis has come up? So what would be pulling the back of that pelvis up? Well, the muscles that attach to the top of the pelvis, the lumbar spine, erector spinae, perhaps the QLs, those muscles that are attaching spine to the top of the pelvis. What could be dragging the front of the pelvis down? Well, those hip flexors. So in its most simplest form, we could think rectus femoris, the psoas, the quadriceps, all of those muscles to the front of the leg, tight, short, pulling downwards. So what does that mean for the antagonists? Well, we can see clearly in this picture how the abdominals are being pulled long. That's not to say they're not tight, they don't have sticky tissue, maybe not mobilizing well, but they are locked long. We need to get them shorter, more engaged, and pulling the front of that pelvis up again. Now, look at those hamstrings. For the back of that pelvis to really come up, they've had to lengthen. And this is one that clients will often talk about where we see this lordotic posture. My hamstrings are so tight, I can't touch my toes. I stretch and stretch and stretch my hamstrings, but it doesn't make it any better. And by the way, I've got really bad back pain. Well, because if you look at that green hamstring line, now, if we stretch that and make it longer, what's happening to the back of that pelvis? It's just rising higher and higher, shortening that back even more. So this is where sometimes people stretch what feels tight and uncomfortable, but don't realize that actually they're creating more length and locking them even long. So we need to think of home care that will help them desensitize those hamstrings, but actually we need them to engage and shorten. So let's just think of our massage strategies. If we create opening, length in that short, tight lumbar spine, and again on that hip flexor, quads, creating space, creating length, now how might that alter that pelvis into a slightly better position? Or at least a position that doesn't cause pain for that client. Our home care, we can then focus on the strength work. But if our clients complain of sensitivity or pain in the abdominals, in the hamstrings, we do not ignore this. We absolutely touch where they have pain, but our focus is on desensitization. So what does all of this mean? Well, no two people are the same, but absolutely people who come in with a lordotic posture complaining of back pain, knee pain, or hip flexor pain will have some, if not all, of these areas as hotspots or tender, soft, locked, short type tissue where we want to create length and space. So we use something called Yanda's lower cross syndrome to describe this. Again, these are observations that Yanda had in clinical practice, where he saw that with lots of people where they had this lordotic posture and pain, he found that these muscles were tight and short. So, if we take this as a basis, but use our hands, our palpation to tell us the truth, because we might put our hands on these quads and realize that actually they're not tight, or maybe just their rectus femoris is, or maybe just their psoas. So everyone's different, but it absolutely gives us a starting strategy, and you will find great results starting in these places. So in the case of lordosis, we tend to see locked short, rectus femoris, hip flexor, iliacus and psoas. The adductors and also that TFL, tensor fascia lata, down to the IT band can be quite tight. So if we're thinking those glutes aren't really firing, they're not really doing much, then we get these adductors, the TFL, trying to create some stability in the hips. We also find calves that are really tight. These are the clients when they lie on the bed, those toes are pointed like a ballet dancer, locked in dorsiflexion. The lumbar erector spina in QLs at lower back tend to be locked short. Again, due to that maybe lack of glute strength or engagement at the right times, we get this overactive piriformis and lateral hip rotators. That's really common in these clients. And those hamstrings, absolutely, are they going to be tight? But remember, locked long. So we want to create tissue desensitization, better mobility in the tissue, but we don't want to lengthen on those hamstrings. And then on the opposing side, what's weak, perhaps, in someone with lordosis? Well, the abdominals and glutes are a great place to start. If you test their abdominal or core strength and glutes, quite often in someone with this lordotic posture, they will be weak. So again, a fantastic first place to start. In terms of their quads, sometimes the lateral and medial quads aren't firing so well. As we said, the adductors and abductors have kicked in, along with that very tight rectus femoris, vastus intermedius. So sometimes getting some better control on the lateral and medial quads can really help, especially if the client's also getting knee pain. We want to get some better ankle control, so doing some strength and stability work in terms of tibialis anterior and posterior and the peroneals can really help get a better gait and better levels of impact and mobility in the body. Let's look at kyphosis. What's happening here? So that's that rounded shoulder, rounded mid-back. Well, what's short? What looks like it needs to create more space? That front of that chest. So just opening up the pectorals, the arm flexors, the biceps can make a huge difference here. We'll often find that the upper trapezius, levator scapula have become over dominant and tight, helping to stabilize the shoulder because the mid and lower trapezius is perhaps weaker. So looking at that posterior shoulder as well. Rectus abdominis. What's going on here? Again, this is an area that, yes, could be tight and facilitated, but also short. People don't really understand why sometimes we want to do some opening up of the abdomen when they're having neck and shoulder pain. This is why. They're curved, they're locked short, those abdominals are shortened. We want to create length and open up the whole front line of the body. But although everything's flexed inwards, head comes down, the people need to see forward. So we get this head up, that correction. And that looks like a head that seems a little too forward when we look at them in standing. So those suboccipitals, those short muscles right at the back of the head tend to be very tight and sensitive. Also an area when it gets quite tight can lead to tension type headaches. So that's an area that often needs opening, lengthening, and desensitization. The lats, the subscapularis, also impacted, as we often see in someone kyphotic, those rolled in, medially rotated arms. We want to get them opened up and laterally rotating better. The QL, again, attaching to the ribs, has a big impact on kyphosis. And those neck flexors at the front, locked long, so we often see a lot of tightness through the SCM, the scalenes, the platysma. But actually, again, it's that correction of the head, chin lifts up, getting a lot of length through there. And on the opposing side, if they're all too short, what's perhaps too weak, too long? The rhomboids, the infraspinatus, the teres minor, those lateral rotators of the shoulder. The mid to lower traps, generally a gomine, we get that stronger, we see real change in these clients with shoulder and neck pain from kyphosis. The thoracic erector spinae, locked long. If you think about that curve, the chest caving inwards, that thoracic spine at the back is so much longer than it needs to be, but so tight, rigid, and perhaps painful. So we want to address it, but do we want to lengthen? Or maybe transverse work would be more appropriate. Serratus anterior. Again, if someone has that winging of the shoulder blade, a lack of scapular control, strengthening that serratus anterior brings that scapula back onto the ribs and gets it functioning better. If they have those short biceps, those bent arms, then doing some work on the triceps to open them up can be really useful. And getting that head in a better position, let's look at those deep neck flexors, longus colli, all of those muscles. Let's get them stronger and shorter so we can hold that head on straighter. Now, let's throw it all on its head. What about the pelvic rotation? I would say most people we see, even when lordotic, one side might be more exaggerated than the other. Or someone might have a very visible rotation, that dip to one side, that rotation to one side. So don't be trapped by this thought of, oh, I've done the lower back on one side, I must do it on the other. I've done this on one side, I must do it on the other. Treat what you see, and your treatment approach on one side of the body might be quite different from the other. And actually, if you trust in your palpation skills, then this will all come together. As even if you work through both quads, you're going to spend less time on the side that releases easier, that isn't as tense, than the side that needs more work. So don't get trapped in this thought that it needs to be a routine, and if you've spent 10 minutes on one leg, you must spend 10 minutes on the other. It's about investing your time where it's needed most for that client. So, now that we've talked a little bit more about posture and about those soft tissue hotspots, how do we bring that into your assessment? So coming back to the O in our SOAP, observational assessment. So what to watch for? So alongside this, there'll be a video where you can see me do a postural assessment on someone. But this basic form, you can change it. It's to prompt you to look at all of these different parts of the body. So looking front on at a client, first I start head down. You could start feet up, whatever works for you. How does their head look? Is it on straight? Does it tilt from one side to the other? Does it rotate to one side or the other? Coming down to the shoulders. Is one higher than the other? Is one more forward, one more backward? Do they roll in, roll out? Are they rounded? Looking at their arm position. Is one hand lower than the other? Is the arm bent at the elbow? Do they look different from side to side? Sometimes a rotation in the pelvis is given away by the arms, one arm more forward than the other. Look at the gap between the hip and the upper torso. Sometimes you'll see, like I always think of them as windows between the arm and the body, a bigger window on one side than the other, indicative of one side being shorter than the other. So again, we're thinking pelvic rotation, perhaps short QL on one side, short obliques. Coming down to the hip. Is the hip level from side to side? Touch those hips. Is it forward? Is it backwards? Is it different side to side? Then let's look at the knees. Are the knees level? Does one knee point in, one knee point out? How do they look? Sometimes you'll see this hyperextension at the knees. People who just lock out those knees. Again, I'm instantly thinking when I look on the side, do they have that anterior tilted pelvis? Foot position. Do the feet turn out? Do the feet turn in? How do the arches look? Are they flat? Are they high? Are they different from side to side? Sometimes we'll see that, especially people with that pelvic rotation that gives this functional leg length difference, that on that slightly longer leg, i.e. that rotated downwards leg, a flatter arch perhaps, but actually on that shorter, rigid, tighter leg, a higher arch. Take note. Looking at the back, I'm looking at scapulas, again head down, so sometimes the ears from the back give a much better impression, as in this picture, this guy's ears are way off. But looking at the ears in relation to the head, again easier to see the shoulder difference in this position. Does one scapula shoulder blade roll forward? Do they wing? Do they wing at the bottom corner? Is the whole shoulder blade winging and turning round? Again, easier to see hip position at the back. Is there a bigger window, a bigger gap on one side to the other? Is there a pelvic rotation? Is it higher one side than the other? Gluteal crease, if someone's wearing leggings, tight jeans, is that gluteal crease higher one side to the other? Arm position again, looking at the back of the knees, are they locked out? Sometimes you'll see that one tight leg, the tendons, the muscles visibly on, aggravated, locked short. Looking at the ankle position down to the feet. Looking at the calves, one developed more than the other. Again, perhaps highlighting a rotation or a one-sidedness in your client. Look at it all, take note, and move on. Looking to the side. This is where we can really see that kyphosis, lordosis, forward head. Does the head come forward? You can see that length through the back. How is that curve through the mid-spine, the lumbar spine? Feel free to ask your client if you can touch the front and back of the pelvis. Does it tilt too far forward? Arm position again. We can see if those biceps are too tight, those arms too engaged, too medially rotated perhaps. And again, look from side to side. This is where rotation becomes so clear. It's like looking at two different people sometimes when you look at one side to the other. Take note, move on, but always have in mind the goal and also your client's complaint. So you might see those arches at the feet, but if their complaint is lower back pain, you might not want to spend the whole session on those feet, but you know that those feet might be playing a part in what's going on. And this is where treatment plan short-term and long-term need to marry up. Now, let's get them moving. So a quick look at the body in front, in back, from side to side. Now that they're moving, what happens? What do the knees do? Do they roll inwards, valgus, or do they bow outwards, varus? What happens at the feet? I'll often see one, especially in that rotation, one foot that flicks out, almost because it is too long, clearing the space. Do they walk with their feet turned out, laterally rotated, light, tight piriformis perhaps? Or do those feet turn in? Look at the foot, what's going on. Does their foot over-pronate when they walk, go into a very flat position? Or is it really a rigid, high-arched foot with lots of impact going on? What's happening at the arms? Is there excessive swinging of the arms, creating power, motoring that client forward because perhaps their glutes, their hips don't have enough power to give them the drive forward that they want? Look at their hips. Does it hike from side to side? Is there a lot of hip movement when they walk, or hip movement on one side? Is there a lot of head movement, a lot of bobbing up and down, a lot of impact being seen up and down the body? Take note and move on. Again, when you come to take all of that together and hypothesize, you will take all of this information and come up with an initial starting point of what you think is having the biggest impact on your client. So once we've done our subjective and objective assessment, we come up with our hypothesis. That's the A assessment. So we've seen lots of good stuff. But say, for example, this client complains of knee pain, anterior knee pain. You've seen that lordotic posture. You're thinking quads too tight, lumbar spine too tight. And actually, when you said to the person, oh, you're quite short through the lower back, they might have even mentioned, oh yeah, I tend to get a tight lower back. It's always stiff. You're looking at their feet. You see a rigid, tight arch, lots of impact coming up. Well, you might hypothesize that it is this, maybe this client's in a little bit too much of an anterior pelvic tilt, and actually you want a little bit more hip control to take the pressure off the knees. Well, that's a good hypothesis. Now, let's come up with a plan. So it's really important that before we apply the massage techniques to our clients, we know where to start. By now, you figured you cannot do good, therapeutic, effective work to the whole body in an hour. So you've got to know where to start. So that client with the knee, I'm thinking I've got a lot of things to start. I know lordotic posture, loosening up that lower back, lengthening through those quads, also doing some footwork, and also maybe doing some home care to help them engage the pelvis better and achieve maybe a little bit less anterior pelvic tilt is going to be a good start. So there's my short-term plan. I can decide what techniques I think will help to lengthen and which techniques will help engage. And it might be that a client doesn't respond to a technique, so you try another one. But at least you have a plan to start with. Once your session is complete, it's really important that you write up your treatment notes. Because although your short-term plan might have been lengthen lower back, lengthen and loosen the quads, do X, Y, and Z, when you touch that client, you might find something totally different. And that happens. And then you're really following your hands for that session and doing the good work and absolutely addressing where they said hurt or where they had pain. But afterwards, taking that time to self-reflect and say, actually, next time, I wish I had have had more time because I actually feel like it's the thoracic spine was the problem for this person. We've all done that. And that's where you take notes and say, next time, you want to start on the thoracic spine, for example. So never panic. There's always more work to be done. And that's why it's important that we always do short-term, medium, and long-term treatment planning. So let's look at a basic example. In a nutshell, our subjective assessment for this client, they complain of a stiff neck, dull pain between the shoulder blades. It's always there. They sit at their desk. It's just really annoying them. So nothing acute, but very much a problem for this client. After doing our detective work into what they do, activities of daily life, we then do an objective assessment where clearly they have a kyphotic posture, forward head, raised shoulders, and a lot of tension in the upper shoulder area. On assessment, I hypothesize that actually a tight chest and a thoracic spine locked in flexion, coupled with this over-dominance of the upper traps that we see and those deep neck flexors being locked short, is what could be creating this neck stiffness and dull pain between the shoulder blades for this client. So neck stiffness being in those locked short upper traps and that dull pain between the shoulders being in those pulled long mid-traps rhomboid area. So what is my plan? Well, my short-term plan might be to do effleurage and petrissage to the upper back, in particular the upper traps and the vater scapula, and into that thoracic erector spinae, so softening that whole area. But I want to do transverse work, STR in this case, to the thoracic erector spinae, so creating mobility through the thoracic spine. But when I turn the client over into supine, I want to focus my lengthening into the chest area. The neck extensors, the scalenes, STR into those scalenes, sternocleidomastoid, and just opening up the chest using some MET. My home care then might focus on stretches and self-massage to keep the pectorals, the chest open, but actually giving them some strengthening exercises for the upper and middle back.